Last session of today, we're going to do, again, I hope this will be a bit interactive. We're going to do an educational update and a panel discussion. And because this is on Zoom and not in Waterton, we definitely have more people coming to help us out than we ever have before, and that's great. So what I'll do this morning is I'll introduce people one at a time, and if they have an update, they are certainly welcome to share that. If they don't have an update, that's okay too. And then we'll open it up to conversation and questions from the audience. And if you have questions of one another, you're free to ask those as well. I'll start with an update from distributed learning and rural initiatives. This is boring stuff to many people, I'm sure, but just so people will know where things are at. We did submit another 3-year grant. We submitted it last January. And it still is not approved. It's still in the government's hands, and it's still, we're waiting for ministerial sign off on that. There's a new minister in that portfolio now, so maybe that will speed things up. The university is backstopping all rural finances right now for us through the university. We have been told that we will at some point get a payment for our first year of our grant, which is right now. So we are continuing operations as usual, but not having a signed grant does have consequences for us. It does limit some of the new initiatives that we'd hoped to proceed within this grant, because new initiatives require new money. So things are hopefully stable from your perspective. When you teach, you hopefully still get a deposit of money in your bank account. But we do recognize that the lack of a signed grant agreement with the government has caused some turmoil for the office and has slowed down some of the new initiatives that I think we're all excited about. So that's our update from DLRI. I'm just going to go in the order that I have people on my speaker's notes here. The next person I'd like to introduce is Dr. Ritesh Ram. Dr. Ram is a family physician in Drumheller, and he is the director of our University of Calgary Longitudinal Integrated Clerkship, otherwise called UCLIC. Ritesh?
Yep, thanks, Aaron. So I'll keep it short. So UCLIC is still doing well. We added a site in this last year, or added it back actually, which was Brooks, which was nice to see. All the LICs across Canada are struggling, and I think rural in general is struggling with trying to figure out why students don't want to go rural. And I know that we've talked about it through this morning, and we've heard from various different people, but it is an ongoing struggle, and it's part of the basics, of trying to educate and convince students that rural medicine is different than urban. And I think that's been a fundamental struggle as to why all the LICs, UCLIC, as well as RICC and Edmonton included, have continually having to advertise and market that rural medicine is different than what you're going to do when you go to your family medicine. So that's been something that's ongoing. We're working with the UME right now to actually develop some markers or some tools that we can use to predict who's going to be best suited for UCLIC in particular, which will be nice. But otherwise, things are going strong, and Albany is very appreciative of the sites and the preceptors that we have that makes the UCLIC program so strong.
Thank you, Ritesh. If people have questions, even as we go through this, certainly feel free to drop those questions into the chat or put up your hand, and then I'll take questions in order that they come up after I've introduced everybody. So the next person on my list is Dr. Jacqueline Hui, and Jacqueline is a family physician by training, but practices a lot of palliative care, and she's the assessment director for postgraduate medical education. Welcome, Jacqueline.
Thanks, Aaron. I don't have a lot to report on my end either, but I just wanted to touch base on FMECAP, and I really appreciated listening in on that talk about spheres of control and influence and advocacy, Aaron. I think what I'm hearing, this group is very thin, overwhelmed, and like many of us are. So on my end, what we can control is not to add more burden to you guys. So there are a lot of things happening around assessment, especially in ECAP. As you know, most of you guys have already started using this electronic platform to assess your residents, giving them feedback through field notes and ITERs. There are some new functionalities that are very cool, but we're not going to be implementing anything yet. There will be a new set of EPAs coming for your residents as well. Again, we're just going to put things on hold. So that is what we can control on our end, to slow things down and to hopefully let whatever is happening ride with this fourth wave, and we'll be a bit slower implementing. So if you have any other comments about ECAP, please let me know. And I did appreciate Dr. Top's kind of shout out to ECAP and continuing to enhance the feedback that we give our residents. And that will be our focus for now.
Thank you, Jacqueline. Next on my list is Dr. Elaine Godwin. Dr. Godwin is in Lethbridge, and she is the site director for the Rural Family Medicine Program based out of Lethbridge. Welcome, Elaine.
Thanks, Aaron. It's nice to be here. Nice to see some familiar faces. I hope everybody's been encouraged by what they've had a chance to learn this morning. And then hopefully getting outside on this beautiful day this afternoon. I think it's supposed to go to 28 here in Lethbridge today. So just to give you an update of what's happening with the rural residency program, there have been a couple changes. We introduced 2 extra seats in the Lethbridge program this year. So we have a total of 16 rural residents, 9 in Lethbridge and 7 in Medicine Hat. I mean, R1s. In total, there would be about 30 if we include the R2s. So the 2 D&D spots were kind of Dr. Jancy's idea to see what kind of capacity we could grow in the rural program. The D&D residents come with a different funding stream. And so far so good. I've been able to find preceptors to do the longitudinal part of their training. Rural sites have been able to add those extra 2 residents and the immersion rotations as well. So that's encouraging. It's been really great to have Dr. Peter Kegler back in the program. He is covering for Dr. Syra Malik's 1-year maternity leave. He started in February, and he brings a wealth of knowledge from sort of the history of the program and connections with rural sites and local preceptors and the history of how things have been done and what worked and what didn't. And that's been really valuable. Probably one of our biggest challenges in the rural program has been the pandemic, as you can well imagine. I see Rick on here, and Rick has been one of my faithful teachers for academics, and we so value his work with boot camp and Sims, and we have some exciting Sims we're planning for February. Hopefully we can get everybody together in person. Sims are one of the things that we can actually gather for, but it's been challenging with a whole bunch of distributed learners who are lonely and isolated and now not seeing their family and not seeing their colleagues, and yet bringing them together doesn't feel like the responsible thing to do, and at some periods of time has been against PGME policy. And so it's been a really challenging 1.5 years in the residency program in terms of resident wellness and encouraging our learners. Yeah, and I just saw a question, what is D&D? That's Department of National Defense. So those residents are funded through a different stream through the Department of National Defense.
Thanks, Elaine. Next on my list is Dr. Martina Barton. Dr. Barton is going to be taking over the postgraduate leadership role for family medicine from Dr. Jancy, while Dr. Jancy is on a maternity leave for the next year. I don't know if you've officially taken over yet, Martina, or not, but I guess straight out of the frying pan and into the fire with this Q&A round here. So I'll pass it over to you.
Hey everybody, I'm Martina, and yeah, we're kind of transitioning over this week and next week. Lindsay's due to have her baby next week, so probably not doing much after that with regards to continuing on. And so with all the handover I've gotten, there's lots going on in the program. And what's relevant to you guys from the rural point of view, curriculum update, we have heard loud and clear from you guys that when residents come to you in their second year for their 2-month rural rotation, you guys feel that, or what we hear from you is that they're not well prepared with regards to acuity and procedures. And so this July, the new curriculum for the incoming R1 class has been updated quite a bit to try and address these concerns. So we have now, instead of 1 MTU rotation, we have 2 internal medicine medical teaching unit rotations in R1. We are also, we are also, we moved the emergency medicine into R1 because we used to have both peds and adult emerge in R2, and now it's going to be, one of them is being moved forward to R1. We also added psych emerge. We also increased continuity in some of our acute care rotations by eliminating half-day callbacks on a weekly basis back to family medicine clinics, and then increase continuity in family medicine by having more continuous 3 weeks in a row as opposed to different configurations. So I'm just saying there are lots of changes to in effect as of July to try and address some of your concerns. And please do keep bringing those forward because we do really look at them. The only other thing I was going to mention is a bit in response to Gavin and his concern about rural representation from rural family physicians on the RTC, the Residency Training Committee meetings. They happen every 3rd Thursday every month, their regular standing meeting. And we do actually have a combined rural and Calgary RTC that's happening. It's a 2-hour meeting. Elaine is there, Peter is there from the rural side. We have rural chief residents, and we do actually have rotating membership of all of the continuity preceptors in rural that we invite on a every 6 months basis. And this is the same as our teaching sites in Calgary. So any site that accepts our residents for rural sites has a chance to come to the RTC twice a year and present a report, let us know their issues and any concerns. And so I hope you guys come when you're invited. So far, and Elaine can attest to this as well, the attendance is pretty low. Like I would probably say most of the meetings where we have rural preceptors invited, they don't necessarily come. I know, of course, Gavin has been a regular, which is great because he sometimes is the lone voice, but I'm just saying it's not for our lack of trying. We would like to include you more and as much as we can. So please do let us know, whether through Elaine or directly to me. And I can put my email and my cell in the chat if anybody wants to reach out about anything. Okay.
Thank you, Martina. And next on my list is Dr. Brendan Miles. Brendan is the Enhanced Skills Director here in Calgary, who kind of oversees all of the family medicine enhanced skills programs at PGME. Brendan?
Yeah, thanks, Aaron. Hi, everybody. My name is Brendan. I'm also a family doctor at the Sunridge Teaching Site in Calgary. And as Aaron mentioned, I'm the director for the Enhanced Skills programs. And just because Enhanced Skills is sort of often potentially a little bit misunderstood, you might hear it referred to as the residents as Enhanced Skills residents or PGY3 or +1 residents. So we have 8 Enhanced Skills programs at the University of Calgary, and that equates to approximately 24 residency positions every academic year across those 8 different programs. And I think the biggest or most relevant update, Aaron, for this group, for the rural group, is a recent change to the funding for re-entry applicants. And re-entry applicants are applicants who are practicing family physicians, as opposed to current R2 residents. And in the past, the funding has been very limited for re-entry applicants or practicing family doctors to apply to 7 of our 8 enhanced skills programs. It's always been open for the CCFP EM program, which has been great. But recently, with the help of Dr. Welakovich and PGME, we've been able to open up the funding for return from practice applicants, which I think is excellent and is really relevant, I think possibly more relevant to rural family doctors who may identify a need in their community of practice and want to come back for some formal enhanced skills training. So just wanted to let everybody know that our Category 1 program applications applications have already closed for the search and selection cycle. We do CARMS earlier than the R1 year. But our 2 Category 2 programs, maternal newborn care and health equity, the application period is still open until the 31st of October. So it's obviously a bit short notice for this year, and we did communicate this as widely as we could in advance, but just to want to let everybody know that for next year, for the next search and selection cycle, in case yourself or any of your colleagues are potentially interested in getting some enhanced skills and then going back to your community to be a resource to your patients and to your colleagues. So I think that's it for me, Aaron.
Thank you so much, Brendan. Next on my list is Dr. Christy Penner. Most of you will know Christy. She is a family physician who works in the Crow's Nest Pass. And we invited Christy this year to this panel because of all of the work she's doing on top of her busy clinical practice. So she does a lot of work with us here in DLRI, helping with our faculty development committee, helping us to develop these events that we put on, but she's also been doing a lot of work at the UME level and within their mentorship program, and she's been active as a teacher this year and has really been a good example I use all the time at the medical school of how some level of virtual classroom can really enable rural docs to be effective teachers within our medical school. So I'll pass it over with that to Christy.
Yeah, thanks, Aaron. That's a great introduction. Really, I just wanted to mention that the Faculty Development Committee continues to meet the 4th Thursday of every month, starting at about 7:30, and it's a super efficient meeting. In 30 minutes, we often get through a lot of topics and plan conferences like this and cabin fever. And if you yourself or if you have colleagues that might be interested in participating, please let DLRI know. We are planning cabin fever in person with a backup plan for obviously a virtual conference in February 2022 in Kananaskis. And please fill out your evaluation forms today for topics that you might want to see there. And obviously DLRI and the Cumming School of Medicine are always looking for more preceptors. So if you work with people that might want to participate and do more teaching, please reach out, nominate them, and encourage them to get involved.
Thank you, Christy. And finally on my list is Dr. Martina Kelly. Dr. Kelly is a family physician here in Calgary. She's an academic family physician with very interesting research interests, and she is also our undergraduate family medicine director. So welcome, Dr. Kelly.
Hi, everyone. I guess the main update from undergrad is that we're driving for the 4+4 curriculum that was put on hold for COVID. And essentially it's where we're trying to get all undergraduates having 4 weeks rural, 4 weeks urban. And so if like Christy said, if you're interested, you've probably had pesty emails saying, please take a clerk, please take a clerk. We're still looking for rural preceptors. So if you're interested, please let us know. That's sort of it, I think, from undergrad.
Well, thanks, Dr. Kelly. I know that Rick had his hand up earlier on. Do you have a question for the panel, Rick?
I did, but I think Jacqueline could have almost answered it. So we're struggling a little bit in our group about giving accurate feedback, but I chatted with you sort of online about that as well too. So maybe just a question, Jacqueline, if this is being deferred, will we be using field notes in non-family medicine rotations with this new electronic program? Is that the plan?
The future plan is to have all rotations use field notes, but that's going to be way down the road. So for now, absolutely just family medicine rotations.
Okay, great. Well, I'll follow up with Aaron and Elaine. I'll talk to Stephanie Brass about some of the challenges they're experiencing, but we can do that at another time.
Yeah, I'd love to hear about them.
Yeah, thanks. And if there are questions, please put them in the chat or put up your hand. I saw there was some back and forth in the chat with Gavin about finding ways to get adequate rural representation on family medicine committees. And I think always a challenge, that balance of the unpredictability of family doctors' lives in terms of being able to commit to a regularly scheduled committee the fact that it's often committee work is typically unpaid work, balanced with the importance of hearing that voice at the table. So I'll open it up to the committee or to the panel about are there any ideas or innovations or ways that we can bring that voice in an effective way to the committees, in a way that works for the rural doctors to allow their voices to be heard, in a way that works for the committees to allow that important feedback to come. Martina, I see your hand is up.
Yeah, I was just going to say, with regards to not being able to attend the meeting at a scheduled time, we do have an option to submit a written report. And also the residents who participate at that site can either attend or provide a report. So if there's a burning issue, but you just can't make it, please do. We have a template form that's sent out every month. And so if you just want to put a little bit of information, and we can always follow up with you after the meeting. So you don't have to feel like if I'm not there, then I can't say anything.
Yeah, thanks, Martina. Yeah, I think Gavin's point is well taken. Can someone cover call in the hospital so that they can attend? And I think that's one of the challenges, is that a lot of communities that are still really active in teaching and taking our learners are truly thin on the ground, and the docs are doing so much and pulled in so many directions, and it can be hard. I mean, sometimes when we make an ask of people, people get upset because they feel that tension, right? They feel they want to participate, but they also but they don't have a lot of bandwidth to participate. And I know that's something I think about all the time when I'm thinking about faculty development committee, for instance, is I'm making an ask of somebody, and people want to give, but I don't want to put somebody in that position. So I don't know that, I mean, I feel like this is an area ripe for innovation almost, or a different way of doing it that might be more effective, because I definitely hear what Gavin's saying, that people aren't necessarily feeling heard.
I could just add, Gavin, I know that you don't see me as a rural physician, but I certainly understand a lot of the challenges, having worked rurally and having done my own call for obstetrics for 12 years, doing one-on-one call. So I totally understand those manpower strains and the call. And right now, I know that our low risk group is often taking your maternity cases when there isn't general surgery coverage. So I do understand some of the issues. And if there are concerns that you want me to bring to the committee when you don't have a set seat at the table for the upcoming meeting, I'm happy to bring that forward. Please be in contact. I'm happy to bring things forward. And I agree with Aaron, if we can find some ways, suggestions are needed though. We can't just be looking at this isn't working, change it. We need ideas.
Yeah, thank you, Elaine. Martina, I don't know if your hand is still up or if it's just.
It's in your hand.
Oh, thank you.
Okay. Yeah, no, I just wanted to mention as well, because Gavin, like I mentioned previously, we are trying to address some of the lack of procedures and acuity for our residents. And so I think part of the problem is that the residents who circulate through your site, sometimes it's a small number of residents out of the whole group. And I don't know, like it might be a bit of a lack of a draw. But we do have, on average, about 70 residents in the program. This is just in Calgary, not counting rural. And we have a bunch of them who are applying for sports exercise medicine, and they have done a bunch of electives in procedural type situations. So I'm just saying, like, you see the residents who don't have it. I know of residents who definitely do. So I just want to point that out. We are making efforts, and you might just get a selection of residents sometimes that are not as strong. But we do appreciate the feedback. And so if you have specific areas, let us know. We do have procedural skill workshops. Unfortunately, again, like just within the last 2 weeks, one of them was canceled literally the morning off because of the announcement from the government about increasing restrictions. So I'm just saying, sometimes we have the opportunities for the residents to do procedures in a training environment, and then that gets kind of snatched out of our hands. So anyways, we're happy to hear your feedback. I'm just saying we're trying. I just don't want you to feel like we're hearing you but not doing anything. So I'm saying we're doing stuff. It just sometimes doesn't work as fast as well as we wish.
Thanks, Martina. I see Francois has a hand up.
Hi, Dr. Johnson. Just thank you for co-chairing this. I just wanted to kind of give a little bit of a background. So I'm a kinesiology graduate background. I'm a community health rehab wellness provider. And I do have an interest in going into the rural community. I've always had for a long time. So my question is how to be able to collaborate with the rural community to help to do an initiation of health rehab wellness programs, because sometimes that's I know through my experience with my mother-in-law, trying to find somebody out in the community, that was kind of challenging at times. And the next closest was Edmonton, which was a 3-hour drive. So by doing something like this with virtual care, there's a lot more access for people to do that. But as a, like I said, community member, how do I connect with the rural community to collaborate? And I just don't know what the next steps are.
Yeah, that's a good question. That's a tough question. I think you know, a lot of sort of rural health workforce work at a policy level. People will say, you know, when a community has enough physicians, that's one thing. But if you can get a PT and an OT into the community, then you've really shown that you have a solidified workforce in a rural community. So it's a good point that that good healthcare in a rural community goes far beyond care that's offered solely by physicians. Yeah, I don't know the answer to that. I think there are collaborators, right? I think RHPAP is the biggest collaborator there. RHPAP, the Rural Health Professionals Action Plan, has an active interest in all health professions being able to, or in rural communities being able to access all health professions. And virtual care definitely has changed the landscape, right? I think there's, you know, it's the we're on that uptake panacea kind of drift off and then find its level curve with virtual care. I feel like we had to uptake it. It was a forced uptake and it was widely uptaked. And initially there was a lot of enthusiasm that virtual care could do almost anything. And I think that enthusiasm has tempered a little bit. There are things that work well on virtual care, and there are things that work less well on virtual care. And now I think we're into that. People are tired of virtual care. They don't like virtual care. They're sick of sitting in front of their computer on Zoom or on the telephone all day. But I think there'll be a rebound to say where is the fit, right? Is the fit that there are certain things that work in certain communities well virtually? Are there communities where virtual care can solve an access issue? So, and that will be different in different communities, I think. So I don't know if maybe that's my best shot at answering your question there. That's a good question.
Yeah, no, it's definitely a start for sure. Like, for example, I'm out of Calgary. So for me, I don't find an issue, for example, driving to a Sundre, driving to Medicine Hat or a Lethbridge to say, hey, let's partner up, maybe do a workshop and then kind of go from there so we could do something live and then tag on the virtual aspect as well for follow-up. So, but yeah, no, I'm just kind of curious about where to start that collaboration and which direction to go towards, and if there's a kind of a openness towards that.
Yeah, I think I mean, we could talk offline about it too, but I think finding one community to pilot something in is probably the starting point. And then there are university and other organizations like RPAP who are stakeholders who are interested in this topic area for sure.
Okay, great. Thank you.
Christy asks, Elaine, can you comment on the teaching topics at rural academics? Are there topics where you need some rural presenters that can present virtually?
I was starting to type an answer in the chat. This has been an area that's been a bit in upheaval this year because of the virtual setting. We use a lot of the regional specialists, and we use the CCFP 105 topics as our guide for topics. If there are areas that a rural doctor would be interested in presenting on, I'd be thrilled to have sessions. We are often trying to balance the resident demand for sim activity with the curriculum expectations. So I find that we're sometimes running out of time. But then there are holes that come up just because of whatever, cancellations, or people suddenly can't make it or whatever. So I'd be thrilled if you know of anybody that has a passion for something. The other thing that I'd be really thrilled to have is if any rural docs are certified as instructors for ACLS or ATLS or Alarm, NRP, that would be a great way to integrate you guys in with the residents, because they all do those courses as part of their academic sessions in R1 and R2. So yeah, Amy Gosvick was our course director for Alarm last year. Yeah, so those are some ideas. And if you know of anybody that has something, I'd be thrilled to hear about it.
Yeah, for sure. I think, yeah, just knowing of my own clinical practice, we've got lots of people with special interests. And then maybe on the faculty development committee end of things, like maybe those are ideas that we, you know, offer an ACLS or ATLS teaching course, or nominate some people to go do that, if that would help the whole faculty.
I have a
Whole
dream
program.
of doing Alarm with the residency program in Lethbridge, and inviting like rural preceptors and the obstetricians from Lethbridge and Medicine Hat. But there have been some, well, obviously the pandemic is probably our biggest obstacle, but.
So if anybody has questions, certainly feel free to put up your hand or put a question in the chat. So there's no questions at the moment, so I'll ask a question which anyone can field. We are hearing that the graduates this year are a little bit different. They didn't have the same medical student experience as we're used to in previous years, and that's manifested differently in residency. Maybe as learner in difficulty, or maybe as like learner who just didn't have as much opportunity as we're accustomed to. And I'm just wondering if anyone can comment on, from the PG perspective, on how we're approaching that or handling that. Whether we expect that we might see some learners in difficulty emerge through the R2 year in greater number than we typically would. And then after that, maybe an undergraduate question. How have we reacted to that at the UME level? How are we trying to mitigate that for this year?
Hey, Aaron, so from the PG side, what we have done throughout these last couple of years of pandemic, we've sent out a survey to our incoming classes to kind of provide us with a little bit more information on what they missed in medical school or what their gaps might be. And we're trying to address those. Like we had a couple of residents who missed their internal medicine in Crookshank, for example, last year and whatnot. So we are seeing what the gaps are. We're trying to address them early on by providing additional experiences potentially, or having discussions with these residents. Given that the rotations in the first year now are definitely higher acuity, like with the MTU, with the Emerge, we do find that typically we address these issues in the R1 before the resident progresses to R2. Like most #1 failed rotation in the whole residency is internal medicine. And that happens in R1. And so the learners in difficulty who struggle with acuity are often identified early. So it's less likely you would find them in rural, not that that never happens, but just kind of statistically speaking, much higher chance to see them early on to struggle and have remediation before they get to you.
Thanks, Martina. Elaine, have you noticed any issues with the R1 class in this regard?
I have definitely had numerous calls about their level of ability, but I haven't had anybody fail. It's just a matter of preceptors have reached out to me because they've been concerned about the residents. And so how I handle that is I reach out to the resident and then just follow them closely. If there's major concerns, set up a focused learning plan to kind of focus on where the areas are that problems are being noted.
Aaron, it's Rick here. We saw this a little bit when we did boot camp for the R1s. You know, they certainly tried, but one thing that was resounding, we did a COVID case of them, and a lot of them said we weren't even allowed to be in a COVID room. So when they when we asked them to intubate a COVID patient, they were all kind of shell shocked. So me being the the eternal optimist, I'm hoping we can catch them up in simulation. I really do. But yeah, I definitely noticed it this year. Like some of them were just saying, we've never seen this. So anyways, I'm eternally optimistic that through a bit of hard work, we can get them where they should be.
Thanks for that, Rick. Martina, any thoughts at the UME level or Ritesh at the UCLIC level about how we're trying to mitigate this going forward?
I guess the first thing would be that the students are now allowed to see COVID patients. So hopefully they'll have seen some COVID patients by the time they see you next year. I think at the beginning there was a lot of confusion about whether students could or not. I think we're in a slightly different space now in that the students are back on main campus. And so some of the deficits, I think, well, I would have experienced with residents in relation to communication skills and physical exam, at least now they're able to do small groups and have a bit more interaction with preceptors and things like that. But I still think there's going to be some issues in terms of just experience and exposure and having them removed from places. But I think there's certainly a bigger awareness that students are part of the team and they are being integrated more into clinical placements, which last year, obviously they just didn't get they didn't get that experience. I think this year will be a little bit better. That's my anticipation.
And Ritesh is not expecting any issues from UCLIC in this regard, and that's what we saw last year too. The UCLIC experience was a robust experience at medical school for medical students in the clerkship in a way that the clerkship the traditional block-based clerkship had a really difficult time replicating. So I'm glad to hear that, Ritesh. Jacqueline, I see your hand is up.
Yeah, I just wanted to comment just from that transition from R1 to R2. In the Calgary program, there were a lot of lost experiences where it really was out of our control, whereby the rotations just didn't want family medicine residents there. They were deprioritized. So OB, one of them, PEDS, PDM, and I know a lot of residents just didn't see a lot of kids. And so you'll probably see a lot of that residual when they come to you. So aside from procedures, they actually didn't see a whole population group. So really, we tried to get them back in, but there are many lost experiences for sure.
Well, thanks, Jacqueline, and a big thanks to everybody who came for the panel today. I know it can be tricky to prepare for a panel discussion because you never know what will be asked, but you've all been great with answers and providing information. So I just want to give a big thank you to each of you for taking the time out of your Saturday to join us today and join our rural preceptors today.